all the pediatricians from Chhattisgarh, they know Dr. Hari. He's a renowned pediatric endocrinologist. He's from Nagpur, and he has publications in national and international journals. He's the first pediatric endocrinologist in Central India. Now over to Dr. Hari.
So, thank you, sir, for the introduction, and I would like to thank Bilaspur Academy of Pediatrics for giving me this stage. बिलासपुर में या छत्तीसगढ़ में whenever I come and talk, मुझे ऐसा लगता है मैं अपने घर ही आया हूँ. Because since last 8 to 9 years, I have been in touch with everyone. मैं पिछले 9 साल से I am giving my services to Raipur and Bilaspur. So, अभी post lunch session, whenever we talk, it is a most difficult session because people are already tired. They have all, had that glycemic food, high glycemic food is consumed, so they feel drowsy. So I'm not going to bombard you with all the technological advances and the basis of this technological development. ना ही मैं आपको इसके डिटेल पब्लिकेशंस एंड ये सब के बारे में बात करूँगा. मैं इधर आया हूँ आपको ये बताने कि जब भी whenever we come across a parent और जब भी हम देखते हैं कोई भी पेरेंट्स के जब बच्चों को हम बताते हैं कि टाइप 1 डायबिटीज़ हुआ है तो that is a state of shock. The first thing comes to their mind is denial, and with that there is an anxiety. एक हर छोटी चीज़ की एंग्जाइटी होती है कि अब क्या होगा, आगे क्या होगा, पढ़ाई का क्या होगा, खेल पाएंगे कि नहीं, पोस्ट बाद में जॉब कर पाएंगे कि नहीं, what all sorts of things including marriage, having kids. Even if the child who has been diagnosed with type 1 diabetes is 3 or 4 year old, this is the problem, or these are the turmoils which a parent go through. So, and we all know that insulin therapy is the only option in type 1 diabetes till we get a permanent solution to it. So what has happened with the advancement of technology, the insulin therapy has been made easier, and it has now become so easier that it has reduced the anxiety. Many of my patients who are on insulin pumps, they are actually able to live their normal life which they were living before the diagnosis of type 1 diabetes. So what is the ultimate goal is for normalization of hypoglycemia. This is what happens in the body. I don't know where the point. So this red line is the glucose, and this is how the glucose rises with every food, and this is how the insulin gets secreted. In the fasting state, the liver is producing certain amount of glucose which is getting released into the blood, and for consumption of that glucose and conversion into energy or putting it into the cell, there is a continuous secretion of insulin by the pancreas. So that's a basal rate of insulin secretion, and simultaneously there are boluses which get secreted from the pancreas. So when we talk about management of diabetes, it is actually walking on a tightrope. On one side, we have got hyperglycemia and its consequences like the microvascular and the macrovascular complications, neuropathy, nephropathy. And we have got hypoglycemia along with its consequences, as well as the morbidity and sometimes mortality associated with it. So it's actually walking on a tightrope. So coming to the history of insulin, this is Banting and Best who actually discovered insulin in 1921. And before that, type 1 diabetes was considered as a lethal disease. So the kids were left to die whenever they were diagnosed as type 1 diabetes. So if we talk about the evolution of diabetes management technologies, we first in 5th to 6th century BC, Indian physician or Ayurvedic physicians, they noted that the sweet taste of the urine of the patient, and they actually coined the name Madhumeha, that is honey urine. And the term diabetes was coined in 1st century BC. So what they actually used to do is take the urine of the patient and put it on the ground near the ants. If the ants are coming near it, they used to label it as diabetes mellitus. So urine testing and urinary strips. Subsequently, there was the discovery of insulin, and finally we had insulin pump therapy, which was initially put forth in 1978, and then we'll talk about the advances. So these are the bad old days of diabetes. Before 1980s, we had only R insulin, that is regular insulin, and NPH lente insulin. Uh, the aggressive therapy of diabetes was considered unsafe because no one knew the benefits of controlling it better. And the target HbA1c was kept at 11 to 12% because it was enough for them that the child is surviving. How long the child will survive, that was not studied. And later on they realized that there are eye and kidney complications happening. So subsequently we got the results of DCCT trial, and actually this trial had shown that intensive therapy, even if whether it is given by pump or three injections in a day, 3 to 4 injections per day, is better than the conventional treatment of 1 to 2 injections daily. And these results appear to show that intensive therapy can reduce both the occurrence and progression of long-term complications of diabetes. So now we know that the basal bolus regime or the intensive therapy is the standard line of therapy. Conventional therapy has been used in pediatrics, but it is a therapy of adults because where we do not require or the lifespan of the adult is not left much, so lesser control is acceptable. But for a child who is 7 or 8 years, if we are not doing a proper control or we are not going for intensive control, then the child is going to land up at renal failure and dependent on dialysis by early 30s or 40s. So when we talk about the DCCT trial, it was shown that retinopathy increases, so that microvascular complication, they increase as the HbA1c increases, and thus the ADA, the American Diabetes Association, has kept a HbA1c target of less than 7. Now, आप लोग इतने सालों से practice कर रहे हैं, you are seeing all the diabetic patients. How many times you have seen kids with HbA1c of less than 7? Hardly any. Hardly anyone. In fact, we keep on trying. I also keep on trying, banging my head. But getting an HbA1c less than 7 was a very difficult target. So, and when we see insights from DCCT and EDIC trials, it says that intensive intervention result in 63% reduction in the retinopathy progression and almost 50% reduction in all the complications. So it is like in intensive therapy. This is a very important message I want to convey, because invariably I have seen prescriptions coming as 2 Mixtards and 1 Ectrapid. So it is a conventional therapy, it is not an intensive therapy. The first thing we need to learn is put the child on intensive therapy, which includes 1 basal and 3 boluses, 3 mealtime boluses, so 4 injections. Because if we talk in the same voice, every one of us, then the patient will understand. Otherwise, just to take patient in or just to take the advantage of their unknowingness, I can tell them, okay, 2 injection में मैं manage करता हूँ, रहने दो, 4 injection बंद कर दो. I get usually patient lost to follow up. And then they are like, they are living with that diabetes, and then they are coming 5 years, 7 years. Now, for 9 years down the line, I have realized that one of my patients, they have come after 7 years because they were put on 2 injections. I told them to take 4 injections, they were on 2 injections, 2 Mixtards, that's it. And the child is not growing at all, is remained short, and there is now microalbuminuria which has been demonstrated. So please make sure that we all talk in the same voice. And literature, there is ample of literature which is there. We should give 1 basal and 3 boluses, that is mealtime boluses. So with this advances, we have post 24 years gone, and we have got developed insulin analogs, we have got improved glucose meters, highly calibrated meters, we have got insulin pumps, and we have got insulin monitoring or glucose monitoring system. So most children and adults with type 1 diabetes should be treated with intensive therapy, and that is to lower the glucose and keep the HbA1c level as low as possible or as close to normal as possible. So this was the first time when insulin pump. So when talking about the physiology, someone thought that insulin secretion in the body is a continuous process. Why cannot we give it as a continuous thing? With that thought process, the first insulin pump was developed by this physician named Dr. Arnold Kadish. And this is how big the insulin pump was at the beginning. But then gradually the pump size came to small radio size, and this was published in the New England Journal of Medicine, that they actually tested it only on 7 patients, and they have said that 6 out of 7 they had glycemia which is coming down, and finally they came with this statement: the feasibility and value of the long-term application of this technique needs exploration. So then it started exploring, and this is the journey of closing the loop. We had in 2006 first pump, that is the first integrated insulin pump and the CGF system, followed by we had got a pump which starts taking action. So this is a smart guard kind of a thing. We'll come to each and individual thing. And we then have a hybrid closed loop system, and then we have this advanced hybrid closed loop system. And that last one is the latest one. So when we talk about Minimed Paradigm 2006 pump, it was helpful. The efficacy, this is a sensor augmented pump, and it had shown that efficacy of reducing the HbA1c by 0.7 to 1.2, in the tune of 0.7 to 1.2 from MDI. So multi-dose injections to pump, when shifted, the average fall was around 1, average fall in HbA1c was around 1. Then we had this closed loop system in which there was a smart guard technology. So this was associated with sensor, and when the sensor beeped at a certain level, the pump used to stop there, so preventing hypoglycemia. So it is like airbag system, in which as soon as it reaches a level of 60, the blood sugar level reaches 60, it will stop giving insulin. And once it rises above 60, then only the pump will restart. So these are automated insulin suspension, and this act like the airbag. What we during accident, it prevents us. So, and there has been experiment where this LS suspension or low suspension was put on and put off, and this yellow line indicates where LS was on, and the blue line is where the LS is off. So this yellow patients, they demonstrated that they were living in a hypos for a shorter duration of time. The hypos were recovering early, and they were not having post-hypoglycemia excursion of glucose. While those who kept it the LS or low suspension and on an off mode, they had more sustained hypoglycemia and more sustained or severe post-hypoglycemia rebound hyperglycemia. So with this technology, someone realized that if we are able to stop that pump before hypoglycemia happens, so this pump was introduced in the next generation, in which there was a smart guard suspend before low feature. So what used to happen is, when the sugar was coming down, the expected sugar was going to go in the blue line, but when the sensor approached the lower set limit, it would stop. It would stop, and the hypoglycemia again, the patient had not suffered hypoglycemia because it is stopping before the patient develops hypoglycemia. And this smart guard feature is, when it was kept on, the number of hypoglycemia episodes they reduced by more than 70%. And if I have to compare it, the first technology was like an airbag, the second was like pre-crash safety alert feature. So we have the same 60 blue line as the lower limit, but it was the stopping at 120 only, so that the patient sways, goes below up to 80 and comes back. So because of the continuous supply of glucose by the liver. So a predictive threshold was, and there were many studies which has shown very significant reduction, almost 50% reduction we can see from 101 episodes to 58 episodes. So almost 50% reduction in the hypoglycemia. And they've actually put in the experimental stage induced hypoglycemia by exercising. And they have actually found out that the number of hypoglycemia is going down. So with this smart guard, suspend before low helps to reduce the lows. And in overall, when we checking about night or daytime, there was almost 75% reduction in the hypoglycemia events. So what happened after that? We had a smart guard hybrid closed loop, that is HCL. There was automation. So it was an automatic bolus delivery. So अभी तक हम क्या कर रहे थे, पंप को रोक दे रहे थे and restart कर रहे थे in a predefined value. The pump was not doing anything else by itself. Now this generation pump, it suspends before low. ये feature पहले वाला था. New feature is it gives automated basal delivery of insulin. So if you are going higher up, it will automatically change the basal rate depending on. So there were algorithms which has developed, and this is how pump works. We have a glucose sensor which transmits the glucose levels, and the pump actually senses it and modulates the insulin delivery. So we have got pump, the algorithm which has been into that. We have got this guardian sensor, and which is linked to the software. So all these are technological details, but what we had till now was adjustment of the basal doses. So what used to happen is when the serum glucose has fallen, there is a change in the glucose delivery, the insulin delivery by pump. When it rises, there were more auto basal increases. So the basal is getting increased. Again, when with the fall, there is reduction in the basal insulin delivered by the pump. And similar thing happened with every fall and rise. Now there was a new parameter, I would say metric, which was initially we used to have the home monitoring or serum blood glucose monitoring, followed by HbA1c. Now time in range is the new metric which has come up, and in last decade it has been shown that recommendation given by American Diabetes Association that a person on an average should spend more than 70% of his time in range. It should be less than 25% above the range and less than 5% below the range. So no hypoglycemia, less than 5% of the time in hypoglycemic range and less than 25%. So if a person is having a glucose target of 70 to 180 in more than 70% of the time, then our job is done. It corresponds to an HbA1c of less than 7. So it actually correlates with the ADA guidelines of less than 7 HbA1c, and thus it improves the quality of life. Because understand, HbA1c is an average blood glucose. So if we are having a sugar of 200 for an hour and 50 for an hour, it constitutes 250 for 2 hours. So it is 125 for 1 hour. So again, the average blood glucose comes to normal. So if we have a normal HbA1c, still the higher sugars are there on SMBG, then we actually check presence of hyperglycemia in between, because average blood glucose will be shown by HbA1c. And we are more worried about time in range now. So to complete this time in range, we had the latest 780G model, which allows for more loading of glucose at the time of meal. So पहले pump क्या कर रहा था was adjusting only basal. This pump adjusts boluses also. So whatever you are eating, बच्चे ने थोड़ा सा खाया, then not in a mood to eat, bolus was set. But because you haven't eaten, the sugar will not rise, and because it is not rising, it will stop giving the boluses there. Similarly, अगर ज़्यादा खाने में आ गया या some sweet has been taken after a meal or just empty stomach, then this will give boluses which are less. Suppose 5 units का हमने खाना खाया and the child was miscalculated as 3 units. So remaining 2 units will subsequently be delivered by the pump. So it adjusts and corrects the glucose based on the glucose level every 5 minutes. So almost 288 times in a day. And it has got a lower default target of 100. So everything starts at 100. Whenever you reach at a level of 100, every algorithm got changed and it starts working. And it offers connectivity and upgradability, that I'll come to it. So it has got basal insulin correction, auto basal is there. So we need not actually arrange or find out the range of basal. It directly, you just have to apply the pump and it will automatically set the basal every 5 minutes. And correction bolus, it auto corrects the high early and in small doses and does help to protect from hypos. So this is how SmartGuard technology happens. There is a selection of basal target between 100 to 120. If the sugar is rising, there will be, once it reaches 180, it will give extra boluses. And once it comes down, it will stop delivering the basal also till the sugar. So there were almost 0 episodes of hypoglycemia with this final product of hybrid closed loop system. And it has reduced HbA1c to less than 7. The time in range target has been shown convincingly above 75%, and time out of range, below range was only 2.3% and above range was only 23%. So we have got a few patients on this and they are enjoying their life like anything. I have got 2-3 patients on this pump and they are like carefree now. They can do anything what they want, they can eat anything what they want, and still their HbA1c is 6.9, 6.8, 7.1. So this is how it has come, and with this 47% of the subjects achieve HbA1c goal after the study versus the 29%, and similarly the time in range, almost 80% of the subjects they achieved that time in range target. So it's a very important finding in this study. Auto correction of the, depending on the carbs it was taken, and 72% of the patients who are on pump claim that they have now the effort to control has been lowered. And similarly, 70% they claim that less effort to keep low blood sugars from happening. So it has prevented both hyperglycemia for a long time as well as hypoglycemia. Now it gives connectivity to your smartphone. From your smartphone you can operate. It gives connectivity to the caregivers. If the child is going to school, college or anywhere, the father or the mother with the smartphone can actually see the blood sugar of the child, wherever the child is. So it gives connection to the doctors, also the treating physician. If I have to see my particular patient's blood sugar, I will just log in to my ID and I just need the patient's ID. Once I have his ID, I will be able to see where he is having hyperglycemia and where hypoglycemia. So this is how the technological advances and data and algorithm has been developed and made life of most of the diabetic patient, type 1 diabetics, not only patients but the family. The whole family, the parents, they have become more comfortable with use of this pump. And now it is like closed loop, whether we are able to, whether we are on a path of making an artificial pancreas, no, but maybe in coming years we'll be having this. So I would like to thank you all for your patient listening. I hope I didn't bore you much with bombarding the studies and all. But this was just a small summary, just to make you aware that insulin pump is one thing, and which has revolutionized the development, which has revolutionized the treatment of type 1 diabetes. There is a stall outside, one can go and see, use the pump, touch it, have a feel of it, वो आप कर सकते हैं. But the most important message what I would like to give here is intensive therapy. Please tell your patient that 4 injections is needed. Minimum 4 injections. Do not compromise on that. That is the most important take-home message. Whether the patient is able to afford it or not afford it, whether the patient gets qualified or not qualified, that's absolutely different. But 4 injections, that should be unanimous. With this, I would like to thank you all, and I'll be happy to take any questions.
Thank you, Dr. Hari. As usual, it was a very nice presentation, and you covered the whole journey. What I could notice The first insulin pump was invented in around 1970, and we are in 2022. So already we are too late to adopt this device. So and I heard that you are only having 2 or 3 patients. They are an insulin pump. So I think this financial constraint is a big issue.
No, two patients on the latest pump.
Okay.
Otherwise, I have more than 25, 30 patients on pump. They are different stages of their development. Yes.
Cost.
Cost of latest pump, it can be worked at around 5 to 6 lakh rupees. Life of that pump, it depends like life of a automobile. Uh, if you are going to purchase a four-wheeler, we don't ask what is the life. Once we are bored, we change or upgrade, or a basic life is around 6, 7 years, 8 years. But I have seen patients taking this pump up to 11 years also. People have been using it up to 11 years.
The problem with that is the automobile is their status symbol, and here they cannot show that this 6 lakh pump is with my
So it's a
in my tummy. So this is not going to give them a status.
Yes, sir, but it is misdirected. You live a good life, that is more important than having a big status.
So that's
Yeah.
what we have to convey to the population.
Yes, absolutely.
Yes.
Sir.
नहीं, यदि
That
पेशेंट
this
को
is the
प्रॉपरली काउंसलिंग किया जाए कि इससे लाइफ कितनी अच्छी हो जाएगी और कितने फिजियोलॉजिकल तरीके से उसका ब्लड शुगर लेवल मेंटेन होगा, आई थिंक 5 to 6 lakh रुपीज नॉट अ बिग
So
money. One can afford.
I would not say that a person coming from some village we should offer it.
Yeah.
But those who can afford should take it. Try to use it. If you are not comfortable, return it. You can always return it. So we have got our representative here, and we can always tell them, they will come to your place, apply the pump, and they go away. They will come after a month, reassess what are the problems, they will try to adjust it. If you are still not happy, return it. Recurring cost, yes, for consumables, almost the recurring cost is 2.5 to 3K, 3,000 rupees. That is the recurring cost, apart from the insulin dose, 2,000 to 3,000 rupees per month, yes.
Dr. Hari, usually what we see in the techno machines, once the new version comes, the previous model, the price goes down. So we can ask this patient, they can go for a
Yes,
not the latest version.
So what has company done is they have come up with this idea that those who already own a previous model, they can upgrade it to the new model, return the previous model and upgrade to the new model with very few, the difference amount paid.
And some of these NGOs, Rotary and Lions, they can also be sensitized, so they can give some donations and all that.
Yeah,
For these patients.
Donations are okay, but I don't know how big donations they can give. But those who can afford it should use it. I think 5% of the patient can afford. That's why I'm saying 95% still they are not getting managed. They are getting managed by conventional therapy. Please put them on intensive therapy. At least their 10 years lifespan or 15 years lifespan will be increased. So that is why I'm talking about pump just to sensitize you. आपको सिर्फ ये बताना है, मैं ये नहीं कह रहा हूँ कि सारे बच्चों को पंप पे लगा दो. I am just telling you that I am here to tell you that such therapy do exist. Because many of us, we don't know such therapy. We are actually skeptical about whenever the cost comes out, and we fear experimentation, everything. So I'm here to tell you that, okay, do not get afraid of this pump and technology. I've got patients who are like 16 years, 17 years, when I tell them, abhi aap acha manage kar rahe ho, now it is time, finally you should pump. Nahi na sir, abhi bhi choti hai. 16 years, abhi kaise choti hai? You should actually try it. And I just tell them, try it. If you're not happy, you return it. So I'm just telling you that such therapy do exist. Some patients, they take it for a longer time to decide. That's perfectly fine. First time, see, I have got a 5-year-old child who was put on pump. Now he is 8 years. What mother used to do is, जितना टिफिन दिया है कार्ब काउंट करके उतना बोलस she used to calculate, put it that 11:30 bolus and send the child to school उतना ही बोल के कि ये टिफिन खा लेना बेटा. The child used to open the tiffin, he used to eat. He has got nothing to do with the sugar, nothing to do with anything else, because the mother has already feeded that a bolus, the time of the bolus and the quantity of bolus. So a bolus उस time पे activate होगा and it will start giving. So just imagine how it has revolutionized everything. So those who can afford, see, it's not everyone will be able to afford BMWs or Audis.
It's not.
But if it is there, then I mean, what's the problem using it?
Actually, the way I look at it, nobody purchases a car with full down payment. Everybody goes for some kind of loan. And if you go for a loan, it will hardly cost you 8,000 or 7,000 rupees per month for the equipment. So that is not a big, I think, hurdle.
Yeah.
And second thing, the way you have explained about the machine, it's kind of artificial intelligence being incorporated into this machine. So we can say that artificial pancreas might be a talk of future, but artificial intelligence coming in incorporation and maintaining blood glucose level to certain level, and that to a cost of say 10,000 rupees per month if you go for a EMI. I think it's a very good or wonderful.
Actually, they have tied up with Bajaj Finance. And
our
0%
hospital has
interest they are
also
putting on
tied up
EMI.
with Bajaj. So even the ICU patients who cannot afford treatment, they get loans. And say if you have gone for a 3 lakhs loan, you will be getting a 6,000 rupees EMI. So it can be done very easily.
It is a 0%.
But we should, if
EMI.
there is some problem, we should look for solutions. And there are solutions.
Yeah,
Wonderful
definitely.
talk and wonderful machine.
Thank you, sir.
Thank you so much, sir. Thank you.